For all of you on the not on the East Coast, good morning. The rest of you, happy noon. My name is Larry Hoffarmer. I am the founder and chairman of the Macular Degeneration Association. I want to welcome all of you. And first of all, I want to let you know that this is the first in a series of webinars for patients that are suffering from macular degeneration. I also want to thank our sponsors, Regeneron and Novartis, for helping to support these events. And I particularly want to thank NotoVision, which you're going to find out a lot about today on their role in helping to prevent macular degeneration. So I'd like to give you a little background on the Macular Degeneration Association. It is a nonprofit health organization. Its purpose is to educate patients with macular degeneration about ways in which they can control it, things they should do and things they shouldn't do. You'll hear about a lot of that today. I founded the Macular Degeneration Association because my mother lost her entire central vision about 20 years ago. She could not see, could not read, but she was a voracious reader. She couldn't watch television, and she even had a difficult time seeing her children's faces. So I accompanied her to numerous optometrists because she thought she needed glasses. When she was finally diagnosed with wet macular degeneration, it was too late to do anything. I had spent my professional career in Washington, D.C. as a healthcare attorney, and I represented numerous patient advocacy organizations. And it became apparent to me that providing education about AMD made a lot of sense. So in 2001, we have conducted on-site programs at different venues across the country, from California to New York, Texas. And since the COVID-19 exploded, these on-site seminars have now been conducted on a virtual basis, in which you're participating in today. We get two terrific speakers today. Dr. Semes is Dr. Leo Semes, serves on our board of medical board. He earned his degree in optometry from Pennsylvania College of Optometry and completed his residency at the Eye Institute at Salus University. He currently holds an appointment as Professor Emeritus of Optometry and Vision Science at the University of Alabama in Birmingham. The Board of Trustees of the university approved the appointment of Dr. Semes as Professor Emeritus in the Department of Optometry. During Dr. Semes' tenure, he contributed significantly to the scientific community, earning a significant reputation for clinical research. As stated in the resolution approving his appointment, Dr. Semes is one of the most accomplished and productive academicians in the School of Optometry at the University of Alabama. So it's now my pleasure to present to you Dr. Leo Semes.
Hello, everybody. My name is Leo, and I have dry age-related macular degeneration. So over the next few minutes, we're going to try and answer the second part of today's title, and that is, now what? First thing we want to do is think about a definition of AMD. And it's important to do that because if you think back to the French philosopher René Descartes, one of the things he said was, if you want to communicate, the first thing you have to do is define your terms. So those of you who have been diagnosed with AMD know that it's a relatively gradual onset, and you may not have any significant symptoms early. But later on, there's reduced central vision or details lost in straight ahead gaze. And I remember one of my very favorite patients. Larry mentioned that his mother was a voracious reader. This gentleman was as well. And one of his first complaints was that he couldn't see where his golf ball landed from his drive on the fairway. So we joked about hitting it not as far and so forth and so forth. And I treated him over the course of probably 35 years. And unfortunately, his dry age-related macular degeneration, just like with Larry's mother's case, robbed him of his central vision and eventually a good portion of his vision. So what we did during that time was to observe what was going on inside his eye through a dilated exam. You've probably all been through that. But on the other side of that is once the diagnosis is made, we have to think about some of our management options. And we have to recognize that there really is no cure for dry AMD. So we have to look at how we can minimize the consequences or slow the progression. Just to give a little bit of a perspective on legal blindness from age-related macular degeneration in the United States, it's far more prevalent, for example, than diabetic retinopathy. And when we think about patients with diabetes, some say that that represents an epidemic. So we might want to consider dry age-related macular degeneration as an epidemic as well. And we're all familiar with open-angle glaucoma, and we'll get a little bit of a closed loop on that just a little bit later. Each of us, whether on the practitioner side or on the patient side, has some value to our vision. And you might look at this American Ophthalmological Society being established over 150 years ago and saying, well, that's an old organization. Well, each year, those who apply for admission have to do some sort of a thesis. And Gary Brown, a number of years ago, back in 1999, decided to address the situation of vision and quality of life. And one of the things that he found was that patients who have 20/40 vision in the better seeing eye would be willing to trade 2 of every 10 remaining years of life in return for perfect vision. Now, the little red asterisk there for 20/40, we can relate to that in a number of ways. 20/40 vision is often a threshold for legal driving, for example, with best corrected acuity. But if we think about another group of patients, and that is patients with severely impaired vision, that group would be willing to trade half of their remaining 10 years in return for perfect vision. So I think this puts into perspective just what the value of vision is among patients in a couple of different categories. And those of you afflicted with dry AMD have a value on your vision as well, whether it's quantitative in terms of obtaining or maintaining a driver's license, or whether it's something like reading or being able to see your golf ball on the course. From the practitioner's side, we have learned to stage age-related macular degeneration. And you may have heard from your provider at what level or stage of age-related macular degeneration you fall into. And where these came from was something called the AREDS. And that's the acronym for the Age-Related Eye Disease Study. It's a long-term, ongoing National Eye Institute study that has looked at patients with AMD and looked at management strategies to try and minimize that. So we'll be referring to this, but as a foundation, it's important to understand that when I say AREDS, what we're talking about. You also may be familiar with the acronym from commercials for the AREDS formula for vitamins. So the simplified staging scheme goes something like this. And if you look at these 2 fundus photographs, which we as clinicians look at every day, they look very similar and they may not be appear to be too disruptive. But in the lower right here, you can see that there are some little yellow dots. And those represent drusen. And that might be a term that you as patients have heard about as well. But as you can see in these low threat categories here, the risk of vision loss from wet AMD is really very, very low. So if you're in category 1 or 2, it doesn't mean that you have nothing to worry about, but your risk over the next 5, and now that's been extended to include a decade, the next 10 years is really very low. But when we look at greater disruption, we see that the risk increases very, very significantly. But something important is that to be included in the AREDS study, patients had to have at least moderate AMD and be over the age of 50. So I'm guessing that most of you who are listening and watching today probably fall into those categories. But if we take our focus to dry AMD and look at what might be characteristic of a patient with dry age-related macular degeneration, to a clinician, it might look something very much like this. And if we take that course of age-related macular degeneration, we used to think that everyone with AMD eventually progressed to the wet stage. And it turns out that that's not the case. It may be that there's a bifurcation and that some patients, for whatever reason, it may depend on genetics to some extent, end up with geographic atrophy or very severe dry age-related macular degeneration, and as a result have poor vision secondary to that, which is not amenable to intravitreal injections such as the wet form might be. And Megan's going to talk a little bit more about that later. So if we can stage age-related macular degeneration, how can we predict trajectory? And again, we have some lessons from the AREDS study. And if we look at this particular fundus photograph, again, our reference dry AMD, we can see that the drusen are relatively large, and many of them are in fact larger in diameter than the width of one of these small veins that exits the eye from the optic nerve head here, the optic disc. This is what would translate into your blind spot, for example. So when we look in your eye, this is about as big as a pencil eraser, and for sake of dimensions, your eyeball is about as big as a ping pong ball. There are some additional risks other than the clinical characteristics that we would observe clinically or on fundus photographs that have come from a recent study that was published from Europe. And clearly, since it is age-related macular degeneration, age is at the top of the list. Family history probably plays into it. The reason that farsightedness or hyperopia is on this list is speculated to be that patients who are nearsighted typically begin to wear spectacle lenses earlier in life, and as a result have some degree of protection from environmental light. And we'll talk about the perspective of that later. Similarly, with cataract surgery, there may be more of harmful radiation and short wavelength visible light reaching the retina. And then one that's very important is the intersection with atherosclerosis. And what we've learned over the last couple of decades is that there are many commonalities between things like cardiovascular disease, atherosclerosis, and other vascular diseases, and age-related macular degeneration. One of those is, of course, going to be myocardial infarction, and something that I'm going to get on my soapbox about, and that is a history of smoking. If we think about age-related macular degeneration as a public health problem and consider the economic burden, it is really quite significant. The numbers here, not only in terms of millions of patients along the y-axis here, but also in terms of the burden on the healthcare system to the extent of over $40 billion a year, really becomes quite significant. And what that means is that there's only so much money and it's all spent on eye care, then there's going to be less money available to manage other disorders such as Alzheimer's disease, cancers, etc. So keep this number in mind with regard to the very significant economic burden that age-related macular degeneration poses to our healthcare systems. So one of the questions that we want to ask is, if we can identify patients early, then we're going to be able to manage them sooner, and we'll talk about the tools for that. But one of the earliest indications of age-related macular degeneration is impaired or prolonged dark adaptation, or simply difficulty seeing in dim illuminations. One of the things that I've come to believe over the course of my years is that the older I get, the more light is my friend. So let's talk a little bit about that and exactly what the connection is clinically between impaired dark adaptation and difficulty seeing or performing in dim illumination. This is a close-up of the retina, and these little boxes here represent the retinal pigment epithelium. And that's a very important transition point between the vascular supply and nutrients from the choroid down here, separated by a barrier that we call Bruch's membrane. And don't worry how to spell it because it's not going to be on the test. But what appears to happen from histological studies, some of which were done by some of my former colleagues at UAB, is cholesterol deposition at the level of Bruch's membrane here, which essentially clogs up that transfer of nutrients to the retinal pigment epithelium so that they can supply the overlying photoreceptors, or colloquially as we know them, the rods and cones. So looking in an eye that has some early changes at the level of Bruch's membrane here might not show up in a typical fundus photograph. So the way we would assess that is to use very sophisticated instrumentation, which is not available in most eye care practitioners' offices, but to assess it from a functional basis, and that is the measurement of dark adaptation. That would allow us to make a diagnosis, for example, of subclinical age-related macular degeneration. So we have a patient who may have some vague symptoms of difficulty seeing in dim illumination, and then a quantitative assessment of prolonged or impaired dark adaptation. But in any of these, whether we look at the other end of the spectrum, intermediate, such as patients would have to qualify for to be admitted to AREDS, we're talking about age-related macular degeneration. So it's a spectrum that is included under the umbrella of age-related macular degeneration. Now, some of my former colleagues also at UAB took a look at a number of patients whom they enrolled in a study of dark adaptation. We'll talk a little bit more about that. And what they discovered from the records of practitioners in the field, eye care practitioners like those of you on this call attend, that about 25% of early age-related macular degeneration is overlooked. So that's significant because it's not the invisible signs of AMD that might be symptomatic, but subtle early changes in AMD. In addition, about a third of patients with AMD that had those large drusen, like we saw in our example, were overlooked, and ophthalmologists and optometrists were about equally at fault. So that was the stimulus and part of what was called the All-Star study. So this is the Alabama study of age-related macular degeneration. And what they discovered was that prolonged or impaired dark adaptation, quantitatively assessed, would show up subclinical AMD at least 3 years before it could be seen, even with some very sophisticated imaging, such as optical coherence tomography, a term that you might have heard of or be familiar with. So if you're fluent in college football and you follow the Alabama Crimson Tide like my wife does religiously, what you'll see is Nick Saban at halftime, regardless of how well his team is doing. They could be ahead 38-7, and he would say, well, we have to do a better job. So as practitioners, we have a burden to do a better job so that we can identify those of you with early age-related macular degeneration and then try to manage the progression of that disease to minimize your possibility for vision loss. So one of the things that we want to look at is a lifestyle profile. Like I said, I'm going to get on my soapbox about smoking. There's a good reason for that. My father was a smoker. It was the cause of his death. But to his credit, he discouraged his firstborn, which would be me. So what about some other things? Diet, Specifically, do you eat a lot of fish, that is especially oily fish? What about wine drinking? What about exercise? And then finally, how well do you think you see? Is it something minimal like, oh, I can't see my golf ball when I hit it off the tee? Or golly, I've had to quit driving at night because I just don't do well in dim illuminations. So these are some questions that we can ask ourselves and also are going to be assessed by your eye care provider. And then finally, we have to throw into the mix, since AMD is a multifactorial disease, is the issue of family history. So this is kind of an overview of our practical management strategies for AMD. And we'll take a little deeper dive into each of these and go through some specifics. Smoking cessation, always at the top of my list. And what we need to think about is the increased risk that smokers have, up to 5 times than non-smokers for late AMD, but many smokers were not advised by their doctor to stop smoking. So our American Optometric Association has an initiative for smoking cessation programs, and we really need to think about how we can invoke that on a personal level, as well as from a clinical standpoint. Dietary and lifestyle modifications. Now, you can go to just about anywhere on the internet, type in diet, and find a whole host of different types of dietary recommendations. But it seems like patients who have a healthy diet, who participate in physical activity, and we'll talk about specifics there, and don't smoke, are at much lower risk for age-related macular degeneration. And as we talked about, elevated cholesterol that leads to atherosclerosis and heart disease seems to be associated with a higher risk of age-related macular degeneration as well. So what we want to think about is perhaps shifting to a lower fat diet with whole grains, fruits, tomatoes, for example, green leafy vegetables, and a low fat dairy component, as well as fish and seafood, because those seem to be protective. And all of these elements of guidance come from something called the Beaver Dam Eye Study. And this is an ongoing study. It's been going on for about the last 35 years in Beaver Dam, Wisconsin. And they've followed patients on a longitudinal basis to determine outcomes. So this really has very good scientific foundation. So as Hippocrates told us, first do no harm. We're probably more familiar with that. Then another one of his quotes, let food be thy medicine and medicine be thy food. So the dietary component here of age-related macular degeneration, the intertwining of atherosclerosis and heart disease really becomes very significant and has quite a long history to it. And that brings us to some current recommendations from the United States Department of Agriculture. This is our tax dollars at work, if you will. And there are dietary guidelines which are available at this site that you can take a look at this document. It's close to 90 pages long. There are a lot of pictures, but it gives some very specific recommendations, some of which are illustrated on the cover here, that really represents a very useful resource for interested patients, as well as guidance for us as practitioners. And one of the things that you'll find in there is the MyPlate. And the idea behind this is that you can see that about half of the food intake here should be represented by fruits and vegetables, and then the other half by grains and protein, minority being protein, but then dairy in its separate orbit here, kind of as something that is optional, if you will. So we need to realize that over time, everything we do is going to be cumulative, whether it's outdoor exposure to sunlight that might result in skin diseases and disorders, or whether it's food that we intake on a daily basis. So the healthier we are, the healthier we can remain. But the Mediterranean diet has some very good science behind it. And this recent publication here from a little over a year ago suggests that adherence to it does in fact reduce the incidence of advanced age-related macular degeneration. If we turn our attention from diet to the exercise portion of lifestyle modifications, physical activity, again from the Beaver Dam Eye study, was found to have a protective association with early and late AMD, and even something as simple as walking seemed to reduce the risk by a significant amount. So the active lifestyle combined with a healthy diet seems to be a two-pronged approach to managing age-related macular degeneration and reducing progression. So how much activity should we get? I think this is a great little scheme here, schematic, showing the transition from screen time to exercise time with the basketball goal there as the marker. But when you look at this first element here, 150 minutes of physical activity a week, that might seem like climbing Mount Everest, but we can break it down. 30 minutes, 5 times a week. So that makes things relatively easy. We have a little bit over a 1-mile loop road near where I live. My wife and I did that the other day. She happened to clock it on her Apple Watch and took us just about 30 minutes. And she got the number of calories and steps and all that. So there are devices that allow us to keep track of that and see just how much exercise we're getting. And something that I've said, I guess, over about the past 10 years since it was first suggested, I think by a group in Australia, is that sitting is the new smoking. So promise we're not going to spend much more than an hour here sitting, and then we can get up and start with our 30 minutes this day of physical activity. Nutritional supplements is an area that's really received a great deal of attention, to the point that the National Eye Institutes organized the AREDS study, the Age-Related Eye Disease Study. And it was very significant in that they took a look at a number of different outcomes and just how well antioxidant vitamins, mineral supplements, carotenoids, etc., reduced the progression of age-related macular degeneration. So the first version of that was AREDS. The 2.0 version, if you will, was the AREDS 2 study. And we have some very good guidance from them about reducing the progression of age-related, macular degeneration. But there are some other investigators that have been working on that, and it's really a tri-continent consortium. AREDS in the United States, the Rotterdam study in Europe, and the Blue Mountains Eye study in Australia. And those results look to be perhaps a little different, but they've really been consulted very nicely by the Tufts New England Medical Center. And that's one of the consistent messages that I'd like to leave with you. So if we look at AREDS 2, we can see that lutein and zeaxanthin seem to be very significant. And those are carotenoids. You know, our mothers all told us that carrots are good for your vision. So these carotenoids are very useful for a number of different functions within the eye. And they also seem to reduce the progression of age-related macular degeneration. Another component of the AREDS 2 study was long-chain polyunsaturated free fatty acids, or the so-called omega-3s. Independently, those have been shown to reduce the progression of bilateral drusen to central geographic atrophy, okay? Not being able to read, not being able to have sufficient vision to legally drive, etc. So while this didn't come as a recommendation directly from AREDS, it seems to be a useful additional component for a dietary supplement for our patients with age-related macular degeneration. And then some of this just reiterates what was shown, but one of the significant conclusions of the Rotterdam study here, along with the antioxidant vitamins and zinc, is that there may be some preventive or protective effect in patients with very early stages from this particular concoction of antioxidant vitamins and carotenoids along with zinc. But the latest comes from a study that was published just a couple of months ago, and that is how these dietary supplements reduce or slow the progression of age-related macular degeneration. And this is the bottom line. High dietary intake of multiple nutrients, including minerals, and that's specifically zinc, vitamins, the antioxidant vitamins, and carotenoids, is associated with a decreased risk of progression. So there may be some benefit, as has been demonstrated, from the omega-3s as well. So if we put all this together, it really can kind of get a little bit confusing here. So you can see my sense of humor. The psychotherapist here is reminding the painter that it is one word. So let's try and condense all this and look at what some folks at the Tufts New England Medical Center have recommended in terms of a very concise recommendation here for patients with age-related macular degeneration. And what this requires is not just a single tablet or capsule, but really a number of different ones. So we've got our antioxidant vitamins here. Haven't really mentioned vitamin D yet, but that seems to be important from some epidemiological studies. We do have the appearance of our carotenoids here, and then zinc, where we have to really minimize the intake of zinc supplementarily because we get most of it through food sources. And then omega-3s at 1,000 milligrams a day, and that seems to be pretty consistent with recommendations, for example, from the American College of Cardiology. So some benefits here that would apply not only to our eyes, but also to cardiovascular health. Systemic disease management, we've talked about cardiovascular disease. We haven't really addressed obesity, but there does seem to be a lot of correlation between those two. And if we can minimize weight gain and minimize the effects of cardiovascular disease, then we're probably going to end up with healthier eyes as well. Similarly with diabetes. And it seems now that diabetes is reaching the proportions of an epidemic. So that, along with lowering cholesterol, seem to be beneficial components in patients who have the comorbidity of age-related macular degeneration. So if you fall into those categories, the message would be manage your diabetes as recommended by your endocrinologist or your PCP, and similarly with high cholesterol, whether that's through diet or whether it's through, for example, taking a statin. And that risk that seems to be associated with HDLs specifically has again been demonstrated in this iRisk study. This is part of the three-continent consortium on age-related macular degeneration. So minimizing high-density lipoprotein intake and adhering to a low-fat diet or using the statin as recommended is going to be very, very valuable. So we can make some healthy shifts here to nutrient-dense snacks, fruits, whole grains, unsalted snacks, sometimes difficult there. Oils, replacing saturated fats. Something that I have a lot of trouble giving up is butter. And then, of course, reducing our sugar intake, because the metabolic pathway from sugar is pretty much to fat. So we want to minimize those things. Some other recommendations, this one from the American Psychological Association, and this is one that appeared just recently. I think it was back in the spring of this year. So I think it's important to recognize that a number of different facets of medicine have addressed what it is to make healthy dietary changes. So when we take a look at these, it's an extra serving of fruits or veggies every day, pass on the salt shaker, start with a healthy breakfast, limit the intake of sugar-sweetened beverages, And I can tell you this, I have probably not had a can of soda for the last 10 years. And I'll tell you in a little minute just why that is. But a couple of quotes there that are significant to that I found. One is from an interventional cardiologist by the name of Asim Malhotra. And he ties increased sugar intake to a low-fat diet and then connects the dots to the obesity epidemic. And then something I thought that was very concise from Professor Susan Jebb at Oxford is sugar is the new tobacco. And then make some of those healthy swaps that we saw in the previous slide. So what you see here behind the sign is the picture of a vending machine, the picture of a drive-through, and the picture of some food sources being advertised on television. And my wife's recommendation to me is, I don't want to see you eating anything that you can get out of a vending machine, from a drive-through, or is advertised on television. And bless her heart, she's the beneficiary. So this might be a good place to start. We've talked about some do's. Now maybe we need to talk about some don'ts. So this is something, and I know Jeff Gerson's going to be watching this, my friend, very good colleague, and our medical director on the optometry side, and he's going to recognize this as a mantra that I have had for many, many years. Another recommendation comes from a colleague of mine in Alabama who is a diabetologist over the course of 45 years. And his has some don'ts also. If it's refined, comes in a box, is white. If you're diabetic, you know, the whiter the bread, the sooner you're dead, but you're allowed cauliflower. Comes with a pop top, contains high amounts of omega-6 fatty acids, and doesn't require at least a few minutes to prepare. Stay away from it. So this is a man, a physician who has dedicated his life to treating diabetics and seeing the awful consequences of that disease and his recommendations to minimize that. So we saw the componentry and the contribution of diabetes and its link to age-related macular degeneration. And this might be another series of recommendations that we can take with very good background. And finally, let's talk about retinal light protection. We get most of our environmental light protection before the age of 21, because that's, as youngsters, when we spend most of our time outdoors. But we need to recognize that this is a cumulative process, and that for folks who are outdoor workers, for example, we really need to think about how we can protect against environmental light exposure. So sunglasses, pretty easy step there. And don't worry about this particular terminology here, but we want to look for blue filtering lenses. And if you've been in front of a screen or looked on the internet, you probably understand the importance of that. But the intensity of that radiation is far less than it is from outdoor radiation or environmental exposure. So we really need to minimize those exposures as patients, and what we can do on a personal basis, as well as practitioners, and what we can do for our patients. One of the ways that I used to monitor progression in age-related macular degeneration was the Amsler grid. And I had a particular fondness for it because it was introduced at about the same time as I came into being. And when we had nothing better, the Amsler grid was really the best, because there was nothing better, there was nothing to compare it to. So if you've been given an Amsler grid by your doctor, you've probably seen something like this, and it's got a set of instructions with it and exactly how you administer the test to yourself and what you're supposed to do if you notice any changes. And like I said, when we didn't have anything better, this was great. But I really lost favor in this probably about 10 or maybe as many as 15 years ago, because we began learning about things like prolonged dark adaptation, and we got to the point where we could quantitate it. So the Amsler grid really fell out of favor. And it's been recently suggested that this is probably not a very good self-monitoring tool. So while it was as good as we had at one particular point in time, it's like the flip phone. Nobody uses that anymore. My wife is in the process of buying an electric car. In 10 years, we'll probably all have electric cars. I have a ICE, internal combustion engine powered car, and she thinks I live in the dark ages. So we've gone through a number of impact points with regard to age-related macular degeneration, and each of you who is a sufferer understands that from a personal basis, but there is also the other side, and that is the burden on healthcare resources. So as clinicians and as practitioners, being aware of that, our role is to try and minimize the trajectory of age-related macular degeneration. So we've talked about a number of approaches to that, whether it's dietary and lifestyle modifications, or whether it's simply starting with smoking cessation, or a few things like taking out of the equation drive-ins, vending machines, and products advertised on television. We can begin to make a dent in the trajectory of progression of age-related macular degeneration. So early on, we can monitor trajectory with the ADAPT DX, which takes a look at dark adaptation, and a device that I actually worked on the prototype of many, many years ago at UAB. It was introduced and invented by one of my former colleagues, Dr. Greg Jackson. So look for that in your practitioner's office. And then for more advanced stages of dry or wet AMD, the 4C home. So with that, I will say thank you for your attention and ask that we postpone questions until after Dr. Blemker's presentation.
Our next speaker and our sponsor is going to tell you how you could prevent the onset of macular degeneration from becoming too severe. So it's my pleasure to introduce to you Megan Blemker. Dr. Blemker is an ocular disease residency trained optometrist who practiced in Nashville for 9 years before transitioning to industry. She was the executive clinical outcome specialist with Bausch & Lomb Surgical for 4 years prior to joining the Nodal Vision team a little over 2 years ago, where she serves as the Director of Clinical Affairs and Professional Relations. My pleasure to introduce you, Dr. Blemker. And I also want you to know I use the 4C Home machine every day. So, Megan, you're on.
Terrific. Well, thank you so much for the introduction, and thank you so much for the opportunity to speak to you all today. It is such a privilege. And to reiterate some of the very important points that Dr. Semes made in his presentation, I'd like to further discuss the importance of early detection of wet AMD and how you can play a role in protecting your vision. So our company, Nutritional Vision, has an FDA cleared and Medicare covered device, which is called the 4C Home. It is prescribed by your eye care professional when you have the appropriate level of vision and the appropriate stage of age-related macular degeneration, the dry intermediate form. And it's a type of personalized medicine because with the 4C Home device, you actually use this at home in between your regular eye examinations with your eye care provider. And the way it works is by detecting metamorphopsia, which is a term used to describe visual distortions when you have that with age-related macular degeneration. So as we've learned today, AMD is the leading cause of severe central vision loss in one or both eyes in patients over 50 years old in the United States. And it's a chronic progressive condition, meaning that it doesn't resolve, it doesn't go away, and it does tend to worsen over time. And Dr. Semes, of course, thoroughly discussed different ways to manage this condition. And as far as the two types of AMD, we have the dry and the wet kind. And the dry is the slower changing, earlier form of the disease, and it actually puts you at risk for developing the later stage of wet AMD. The prevalence of dry is about 85 to 90% of patients. And then wet AMD, of course, is the sudden change or more advanced form of the disease with the prevalence of about 10 to 15% of patients. So what is dry AMD? It affects the macula, which is responsible for the detailed central vision, like reading, driving, seeing faces clearly. And it's at the very center of the back of the eye there, the macula in the middle of the retina. And over time, small fatty deposits begin to form, which are called drusen, that Dr. Semes discussed before. And so because this dry type of AMD is slow, you may not notice the changes over time in your vision. Here's an example of those drusen and where they're located in the retina. And so if you convert to wet AMD, abnormal blood vessels actually grow under and into the retina, and these blood vessels can leak fluid and can bleed without warning. So the dry form of AMD can suddenly change to wet AMD without any kind of advance notice. And again, you may not notice these changes until significant vision loss has occurred. So it can be rapid and severe. And some of these symptoms of wet AMD actually include distortion, dark spots in the center of your vision, or just generalized blurry vision, with an example here you can see on the screen. Unlike dry AMD, there are actually more effective treatments for wet AMD. However, these are most effective whenever they are administered early on, before symptoms are noticed and before vision loss occurs. So this again reiterates why early detection provides the best chance of helping you maintain good vision and maintain your independence. Because once it starts, it will continue to advance until you receive treatment. And this irreversible damage can actually occur within days to weeks before the symptoms are even noticed. So how can you play a role in protecting your vision? Through at-home monitoring. And again, as Dr. Semes discussed, a lot has changed with at-home monitoring over the years. As you can see on the left side of the screen here with an example of that Amsler grid that the person is holding up there, introduced in the 1940s and is the standard of care. What we've seen with clinical studies is that only about 13 to 41% of patients using this standard of care alone are maintaining that driving vision, that level of vision of 20/40 or better, compared to the 4C Home AMD monitoring program, where 94% of patients were actually able to maintain driving vision 20/40 or better when it was added to the standard of care. So when we're telling you all these numbers, I know when you go to get your eyes checked and you look at the Snellen chart, the chart on the wall with all the letters on it at the doctor's office, the higher the denominator or the bottom number, the worse the vision. And again, as Dr. Semes had stated, the 20/40 is kind of our typical benchmark level for driving and just activities of daily living, being able to maintain your independence and do those things that you enjoy doing every day. So 4C Home is something that is added to your eye doctor's exams and the protocols that they have in place for managing your age-related macular degeneration. So it's an early warning system for your eyes. You can see an image of the device over here on the left side of the little viewer. And the way it works is you take an easy daily test that checks for these tiny distortions in your vision. It only takes a few minutes per eye per day. And then the data from each of those tests is actually sent to the Nutritional Vision Diagnostic Clinic, the medical service provider of 4C Home, for evaluation. And then that information is provided to your eye doctor. So if there's a change in the test score that's detected, the same diagnostic clinic actually alerts your doctor, and then your doctor contacts you directly to schedule a follow-up visit to come in and have your eyes examined. The testing is easy. Pretty much you turn the device on and then you look into the viewfinder to begin the testing. And then when you take the test, what happens is you'll look at the center dot. So right here in the middle, this green circle, you'll look at the center dot, and then in your side vision, a bump will briefly appear and then disappear. So you'll use the mouse that's provided to click where the bump appeared, and then you go back to the center dot and then repeat over the course of those few minutes. And once you're done with the test, the results are actually sent to the Nutritional Vision Diagnostic Clinic for evaluation, and then it's provided to your eye doctor. So this at-home monitoring it's a good, healthy habit you do every day to help preserve your vision. It's like brushing your teeth, and it's something that you incorporate into your daily routine. There are little to no out-of-pocket costs for the majority of Medicare patients. As I'd mentioned before, it is FDA cleared and Medicare covered. And so patients with Medicare and a secondary supplement plan could have out-of-pocket costs as low as $0 per month. Patients with Medicare and no secondary supplement plan actually pay $15.03 per month once your your Medicare fee-for-service Part B deductible is met. And we have a whole team. The No Television Diagnostic Clinic has an entire team dedicated to insurance benefits, eligibility, and verification. And this team would actually review with you in detail any potential payments prior to your acceptance of the 4C Home AMD monitoring program and prior to shipping you the device. So to take the proactive approach with protecting your vision, you need to get started with 4C Home. A clinical partner will be with you for every step of the setup process. After the No Television Diagnostic Clinic receives the prescription from your doctor, you'll get a call to answer any questions, verify the insurance coverage, go over any payments, and have the device shipped to you. And then once you receive the device, the No Television Diagnostic Clinic will walk you through setup and training. So you'll continue to receive feedback from the clinic throughout the process. And again, it allows you to take a proactive approach to protect your vision, because by extending the care into your home, you can be involved with your own eye and own health care. Thank you so much.
You can start your questioning. Just please address it if it's for one of the other speakers, address it to the specific speaker. Otherwise, ask your question and they'll respond accordingly.
One question, Dr. Semes. I particularly enjoyed and appreciate your conversation about discontinuing smoking. And there's a question here, do you want me to quit smoking, doctor? Do I have to quit drinking too?
It's interesting that you ask that question, because I've been asked that question by my patients. And smoking's been very significantly tied to progression of age-related macular degeneration. So that's both hands on the table. In the Beaver Dam eye study, what they took a look at was a number of behaviors, including smoking, drinking different types of alcohol, which is wine, beer, and hard liquor, and physical activity. So what they discovered was, and that was one of their recommendations, that physical activity and smoking cessation are far more important than any alcohol intake. And the alcohol intake that they assayed from the participants was 4 or more drinks per day. So when you think about that, that's well into the category of heavy drinking. So they did not find that was detrimental, but by no means does that mean that I want to encourage my patients to have 4 or more alcoholic drinks a day, because there can be some other consequences from that. But just like the Greeks said, anything or everything in moderation, I think should be the watchword there. So sorry for a long answer to a short question.
I have a question about smoking. What is it about smoking that increases the progression of macular degeneration?
It seems, Larry, to be an oxidative process, that the cigarette smoke just deprives tissues at the cellular level of oxygen, so it decreases optimal functioning and wears things out. I guess the analogy that I could use is that it would be like running your internal combustion engine car without oil or cooling fluid.
Well, cigarette smoking, how about cigar smoking?
It's really not been broken down like the Beaver Dam eye study broke down different types of drinking. So cigarette smoking, cigar smoking, pipe smoking, we'll probably have data on cannabis smoking, marijuana smoking in another decade or two. But it seems to be the oxidative response that is most significant there.
Great. We do have some more questions coming in, Dr. Semes. The first question, my 88-year-old mother has dry AMD in the left eye and wet AMD in the right eye. Will the AMD monitoring device help her? Excellent question. Absolutely. So particularly with patients who have one eye who has converted to wet AMD and the fellow eye needs to be protected. They're, of course, at higher risk for that fellow eye converting. So absolutely, this could be something if it's at the appropriate stage and appropriate level of vision of dry AMD, absolutely protect that fellow eye with 4C Home. How does one start with 4C Home device? For example, what is the first step? Do I get a prescription from the doctor? Absolutely. So that is the first step. You would go in for your regular eye examination and discuss the technology with your doctor. They would deem if you're an appropriate candidate, and then they would send in the prescription to our no television diagnostic clinic.
And I have a question that I can answer from a personal as well as a clinical perspective, and that is floaters. I have very bad floaters in my right eye, and that's a separate thing from drusen. So I don't think any retina specialist would ever refer to drusen as floaters. Floaters are within the vitreous, within the gel of the eye, and they're opacities that move with your vision. Whereas if you had a very small blind spot due to an individual druse, that would travel with you, and many drusen together congregating would represent geographic atrophy, and that would be a blind spot that followed your vision. So if the floater moves with your vision and then takes a while to catch up, it's more likely to be in the vitreous.
Great. I noticed my floaters on like a bright sunny day when there's a clear background. It's you can see it's like a snow globe in there with the little pieces moving around. It's very noticeable and very frustrating at some time.
And there's a question about beta carotene. Beta carotene was the carotenoid that was included in the original AREDS study. And what was discovered was that there was an increased risk of lung cancer among smokers with beta carotene. So for that reason, lutein and zeaxanthin were substituted as the carotenoid components in AREDS 2. But if your risk for age-related macular degeneration is, let's say, for lung cancer is 90%, if you're a smoker, then it's probably going to increase just very slightly if you take beta carotene. So if you're not a smoker, beta carotene's not going to hurt you, but if you're a smoker, the smoking will.
There was a question from the audience. 2 weeks ago, my provider told me that Medicare no longer covers the device. So there was a time toward the end of 2018 when Palmetto, our Medicare administrative contractor, was actually reevaluating some of the codes for technologies and for screening versus diagnostic services. And so that has been sorted out. There has been no change in coverage for patients. It has been continuously covered the entire time, but there was that question that was brought up at one point in time. But all of our patients have been covered and continue to be covered by Medicare. So.
And there's a question about are there certain types of meats that we should avoid more than others? Interestingly, earlier this week, there was something, I think it was on Medscape, and it talked about the 5 meats that you should avoid. And I'm going to put avoid in quotes because they were pretty much talking about red meat. And they included in that pork and fatty meats such as bacon. So again, everything in moderation. You don't want to be having tenderloin for every meal. And by the same token, you don't want to be having bacon for every meal. But the whiter meats, such as chicken and fish, seem to be more beneficial than the red meats. And then another question about what if you have not smoked in 35 years? My mother always taught me never ask a lady's age, so I won't ask how long it was that you did smoke. But having not smoked for 35 years, first of all, hats off. I think that's definitely a step in the right direction. And there have been studies that looked at smoking, former smokers for 5 years, former smokers for 10 years. And one of them related it to the risk of lung cancer and beta carotene, so not directly related to eyes. But if you hadn't smoked for 10 years, your risk went down dramatically. So the extrapolation that I would take from that is that if you've not smoked for 35 years, you're probably very significantly depressing or diminishing your risk. So again, hats off for quitting and being on the right track there.
Well, I guess that's everybody. The questions have been asked and answered. I want to thank our participants. I want to thank our sponsors, and mostly I want to thank all our participants who are dealing with macular degeneration today. And I hope you stay safe. Have a good day, everybody, and thank you. And I hope to do this again soon.